All right, so can you hear me all right? All right, I have a tendency to walk around. It's not that I'm a nervous Nelly or anything like that, but I just like to walk around. It's a lot easier for me. Silver State ACO, name of our state, right? Silver State ACO. So Stavros Anthony, as you know, Silver State. Most of the people don't know it. I've been wearing my badge up here with an American flag and the Nevada flag, and 90% of the people look at it don't know what the blue flag is. That's kind of not so good. But anyhow, it is what it is. It's our state. So what is Silver State ACO? Difference, and Ernie said it kind of nicely. He doesn't even know the difference between the HMO and the ACO. Our ACO is self-Medicare, who people are on Medicare, fee-for-service, traditional Medicare. So it has nothing to do with the HMO. It's a voluntary organization. It's volunteer from the physician side of it. Most of the patients don't even know they're part of the ACO itself. So what's our background? Well, we started way back in the day in 2013. We put our application in. We started in 2014. And at that time, you know, it was just a shared savings, a 50-50. If there was savings, we would get 50%. CMS or Medicare would get 50%. And as you know, with the government, that's never the truth. They took 2% out for sequestration. They took some money out because we didn't meet a standard that we didn't know was a standard. But nonetheless, it was an adventure in that first year in 2014. Our service area, we started out just in southern Nevada. And then we went out to the rurals with the Nevada Health Centers. That gave us access to Carson City, Ely, Elko, and some of the other parts of our state. And they do have a large presence here in southern Nevada themselves. Then we were able to go up to Northern Nevada Medical Group, which is owned by the Universal Health Services and UHS. And so we started going up into that area, which is dominant by Renown. And so you have Renown and you had St. Mary's, so both of those had a large medical presence, and they started their ACO up there as well. And we competed with them very well. And then our practice is led by approximately 730 physicians. We have a board that's made up of physicians, so 75% of our board are physicians. And so they actually can help direct and control where we're going. Actually, Dr. Soloway here has been on the board since day one. I know he only looks like he's 40, but he's been on it from day one. And so we have our monthly meetings. We go over what our plan is, how we're going to go ahead and direct what we're going into it. The good thing about it is in our first year, we lost money, which is not unusual in a startup company. But in the 6 years since, and hopefully we will know in the next couple, 3 weeks, we've made money. We've been able to return a lot of that money back to our physicians. And during this whole period now, from 2015, our second year, to 2020, which is our 6th year, we've saved $162 million. That's just in our little state. So that's a pretty big thing. Now, unfortunately, the savings means we got part of it and Medicare got part of it. So they did actually have true dollar 100% savings in that respect. But for a small state of Nevada to be able to have that much of a savings, we've got a lot of good press nationally. We've got a lot of good press even somewhat internationally. But the most important thing is that we've been able to ask our doctors with data, can you help us figure out how to get people who are old like myself and are on Medicare not to use the system redundantly? And that's really what it amounts to. You don't know that your internal medicine has done an EKG and maybe they've done a nuclear test on you, and then you go to the hospital, they repeat the EKG, they repeat the nuclear test, and now you're having duplication of testing and services, and not necessarily complete care at the same time. So that's really been our whole mission, is being able to give the doctors, our primary doctors, who make up all but 4 of our practices out of the 50, is it 58 or 59 right now, of the practices. But so, again, it depends what publication you look at. We're in the top 6%. I always say the top 10% in the United States. Currently there's about 500 plus ACOs, and totally there's been almost 1,000. So that means 500 of them have gone out of business for whatever reason, through consolidation. They weren't successful. doesn't really matter to us. So we've been in the top percentages for years. We've been out of the top, in 2020, out of the top 10, we were ranked 8th in earned savings. So in other words, the money we actually saved and brought back into the ACO, number 8 in the US, and then 2nd in the per beneficiary savings. So we look at that as our biggest cornerstone. The average Medicare patient is about $11,000 to $12,000 per year per member, right? In a managed care, an HMO, in Ernie's case, he may abuse the system, but because he $250 for a call to say he was okay. But it's about $8,000. That's $4,000 difference between a managed care system and a non-managed care system. So again, myself, or my wife more specifically, she does not want to be with an HMO because she doesn't want to not have the choice. But realistically, it's still, there's a limited amount of people who are going to see you. There's a limited amount of specialties that can see you. So in one sense, it's still a mindset for her. And I don't think I'm ever going to change her mind. But it is what it is. So we look at it, we still have opportunity for savings right now. So even though we're at $11,500 is our benchmark, that's what our spend is, and it's less than the national average of all the other people that are on in the ACO system and non-ACOs, we still have a good pathway that we can reduce costs, we hope, down the road. So what did we do? Our challenge was to try and improve quality. And the only way you can do that is if you can get people to understand what their own health care is. You know, how many times have they, if they're on diabetes, are they getting their A1C quarterly done? Are they going for the regular routine checkups? Have they had their annual wellness visits? And I'll get into some of that stuff. But those things that will improve quality will help reduce the cost. But the patient has to be incentivized to do something in here. And then from the challenge to our doctors is if you do that extra work, you should be able to increase revenue to your practice. So we do know that 43% to 45% of the dollars spent are spent in an inpatient or an acute setting. So if you can just save 1 admit per year, 2 or 3 emergency room visits, that's thousands of dollars. The average admit to our ACO is probably $14,000 to $18,000. Whether they stay a day or they stay a couple weeks, it's money to the ACO that it's costing the government. If they can go to that doctor 52 weeks and the doctor gets $100, that's $5,200. So that's a big difference if you can get the patients to stay engaged with your primary care. So that's what we're trying to tell the doctor. Your patients will get a better improvement in the quality, you're going to get increased revenue, but you've got to help decrease the utilization to the emergency rooms and to the hospital. Some of that's possible, not all of it. All right, so what did we do? Annual wellness visits. A couple years ago when I turned 65, I said, I'm going to go check this out. Scared the hell out of one of our nurse practitioners because we were managing the practice, and I said, I want to sit down and find out what are you talking about when you do this annual wellness visit. And it's amazing that I didn't know anything about myself, so I brought my wife with me because she remembers all that stuff, a former nurse. She knew I had basal cells, she had this. I didn't remember any of that stuff. It was just, you know, I went to the doctor, they did their thing, and I forgot about it. She had copious notes. So she knew everything and was telling all this stuff. By the time it was done, they had a great conversation, and I just listened, and I was like, wow, I didn't realize all that stuff. And then they asked me to go do these things, which 2 years later, I still haven't done any of them. But the important thing was that I tried it out. And that's what we want the patients to do. The other thing that we found has been very successful is chronic care management. So CCM, we sell this to the physician practices as a concierge type atmosphere. If you can talk to that patient once, twice, 3 times a month in this CCM program that Medicare pays for, it was $43. So not a lot of money. This year it changed to $61. I think they finally figured out this is very, very beneficial to the patient. If you can talk to that patient and let them know, how come you didn't go to the doctor's office last month when you had an appointment? How come you haven't been taking your medications? Did you go to the kidney doctor? Did you go to the urologist? Whatever you're needing to do, can we help facilitate that? When you engage that patient, now you've got someone reminding them to do things. My mom is 92 years old, luckily. And we've been trying to get her in this, but Kaiser's got a program in California that she's been involved in. But we finally got the doctors to say, look, just send somebody out there every 2 weeks, like a home visit, just to make sure she's following up on a couple things that she needs to follow up on. And it's reduced her emergency room visits. So again, it's a great program. And then the last one, which is very significant, is that transitional care management. Patient gets discharged from the hospital. At best, they kind of remember what happened to them in the hospital. At worst, they don't remember a darn thing. So you've got companies like we use ACOs right now and Dispatch Health. Those are the two entities. They're talking to these patients when they leave the hospital to remind them that they need to go see their primary care, or they need to see their cardiologist, or they need to see their specialist. And if we can reduce that readmit rate, which is very high in Nevada, it was about 1,900 patients per 1,000 come back in, or 190 days. So we want them to not get readmitted, because that's very costly. And unfortunately, the hospitals can also get penalized because the government thinks maybe they discharged them early. So then there's some penalties that are associated with that. So we've got two companies that are focused on this, trying to make sure that the readmit rate is going to be low. And we started off kind of high, and we reduced it by about 40%. And so that's a big savings. Again, not only not having the patient go back into the hospital, but just not incurring that additional cost. Getting the patient involved in their own care. Very difficult, but that's what our goal is. So our challenges, and this is probably a nice screen, because how do we actually get a physician to change their behavior? In 49 years, 1973, I couldn't do it in the emergency room when I first walked in the emergency room and was working as a file clerk in the hospital, and I realized that doctor is not going to care what I tell him he's got to do. The medical records people aren't going to let him sign something that he doesn't want to sign. So we've got to get them in some way to use the analytics and the tools that we give them to get them to believe that what they're going to be changing was their idea. And that's what we've really done. It's kind of like the magician, right? You've got to get them involved in it, the fact that that was their idea and that they can actually be the influencer to the patient, but we've got to somehow change their behavior, but make sure they understand it's them that made the idea, that they're going to change their behavior, not us. So coordinate the care and to control the cost. And again, going back to, the cardiologist is doing 2 tests on a patient. They send them back to their internal medicine or family medicine doctor. He does the same 2 tests over. We don't have that wonderful, sharing of data that's accurate, even with Healthy Nevada and things like that, that we do have common software, but it still doesn't talk to each other properly, and it's not easily to see it. So, but you want to coordinate that care. And then we focus on certain things, management of specific quality improvement plans. So when we put these plans out to the physicians, we actually tell them, here's what you haven't done on a patient according to Medicare's guidelines. Not necessarily according to what you want to do with the patient, but Medicare gives us regulations and rules, and it gives us statistics, and that has to be documented in the way Medicare wants it documented. Cardiologists could care less what Medicare thinks, because if that patient has got a 120 over 80, that's a good patient, right? Medicare says, no, that's probably close to being pre-hypertension. So you got to do something about it. A fall screening test. There's nothing wrong with the patient. They came up and they did their, a PQH9 or something like that. You run this test and there's nothing wrong with the patients. I've never fallen, nothing like. Medicare doesn't care that the document says that. The doctor needs to notate it in his chart that the patient has had nothing done, no falls. Otherwise, we get dinged for it. So again, those are the rules, just like everything else. And banking, Walter over there, he's got probably as many rules as we do. But it's a challenge to get the doctors to change the way in which they chart things that we hope will actually improve the care down the road. Then, utilizing it to influence behavior. We already talked about that. Coordinate care. I got ahead of my slides here. All right, so our approach was evaluate available resources. So when we first started this out in 2011 and 12, Mr. Wiggins and myself, we started another ACO, and we got in with a partner that wanted to do everything himself, create it all. Well, we realized that's absolutely the wrong way to do business. We need to find people that are already experts in IT or expert in data collections or experts in something else, and use their knowledge with our dollars to be able to move forward. And so when we started Silver State ACO, that was the first thing we said. We're going to go out and bring partners on in that know their specialty, or their side of their technology, or their side of their business. Not our side of the business, their side of the business. And if we can collate that information, we can do things that probably most of the other ACOs in the U.S. have not been able to do. Experian was a good one. Most of you know that if you want a credit, you're going to get an Experian report. But do you realize Experian probably collects more data than the federal government? Your credit card information, your mortgage information, your housing, your daughter's schooling, they probably got everything that you never believe it's sitting out there, and in some way they can pull that data down. So when our large competitor here in town, Intermountain Health, previously it was Healthcare Partners, they tried to do something with the hospitals to get this data collected so that when a patient gets admitted, they would know that. And for whatever reason, it didn't happen. So we sat down, and Health Information Management Society and Systems was having their national convention here, and one of the guys from Experian was here. And we sat down and said, well, look, why did it fail with them? And they're the largest provider in town, big national, why couldn't they get it done? It was just, they weren't speaking the same language. So we did one of those little Southwest deals. We took out a napkin and I wrote down, here's what I need, what can you do? And he said, well, here's what I can do, what do you need? We put them together, and the next thing you know, we were able to get data between Universal Health Services, HCA, we were able to get data. So now when a patient gets registered into the system, Experian, for probably 80 and maybe 85% of the hospitals in the nation, Experian confirms that they're really on Medicare, or if they're on a managed care program. So if they can do that, and we can send our database to Experian once a month, anytime a patient comes in that's our patient, it hits that key. 4 to 10 seconds later, we know the patient is being registered in the hospital, whether it's an emergency room or whether it's being a true admit or not. Then possibly we can do something about it. Either send somebody to the emergency room, hospitalist, cardiologist, do they really need to be admitted or not? Do they even need to be seen? So that was a big one, and they've been with us since day one. Again, technology. Filtering through the data is the hardest part, because the last thing we want to do is give the doctor 40 pages of reports when he's got no time to even do his charting. So what we try to do is give him a minimal amount of data that says we think you can make some effective changes by doing the following. Just get the patient back on in, or how come you haven't done a gap in care report on one of their major diseases, and then using some of the tools for the education of that. And a lot of that is going back to talking to the doctor about educating the patient, not necessarily the physician, but educating the patient. Not someone like me who doesn't want to listen to that, but that's what you do. So the next part of it is evaluating all of our resources, like we're talking about, filtering through the data and education, going through our historical trends. This is probably the stuff that I like the most, and most of my staff hates. But I love to be able to look at historical and find out what have we done that was successful that we can keep moving forward and build on that success. And I think that's probably the hardest part about anything. We get our data late. It's not always as accurate from the government as we expect it to be, but we do get a lot of data from them. So if we can look at what we've done in the past, that's probably the best indicator of where we're going to go in our future. So this is a chart that you may or may not be able to see, but from 2014 to 2021. In 2014, that was our first year. So the quality score on the bottom probably would have been 50%. It would have been terrible because. All right, and yeah, Diego will have them out on the site. Okay, so if you look at it, we were hoping to get about 5,000 lives, 8,000 lives. We ended up with 12,000 lives in our first year and no quality score, luckily, because we knew it wasn't going to be very good. In year two, we went up to 14,000, and 87% was our first year. So we were pretty happy at 87% on getting a quality score. And we grew our practices, and year over year, we were doing some growth, not for the sake of growing, just people were interested in what are we doing. And so that was a big one. And again, in year one, we lost money. In year two, which we got in year three, we made money. It wasn't a great deal of money, but it was money. And so our quality scores went up in 2017 to 90%. Okay, we finally figured out, we've got what we were going right. And then what happens? The government changes the rules. And they change the scoring. So, all right, well, they changed the scoring in October for January. So we didn't have time to go back and get the doctors to start looking at things because if the patient's only seen once or twice a month and they were seen in January and maybe March, you can't make any change in the chart through the rest of the year because you'd have to bring them back on in. So we had a little dip in that. Then we had this huge, huge change in 19, 96%. I will tell you that's probably the best thing that I ever thought we did. We were absolutely able to make significant improvement. And then in 2020, we outdid ourselves at 98.75%. Now, that was our COVID year. So I really can't give a lot about 20 because the government gave us a pass on a lot of things. They had to tell us, look, we can't blame you for certain things. People weren't coming in the hospital. The ones that were coming in the hospital, God only knows why they were there, but so it was a false bump. I'd love to take credit for it, but I got to hang my hat on 19. That was a solid year. We know what we did. We know what we did, what mistakes Medicare told us we did from 18 to 19, and we had a huge increase, and we're very, very proud of that aspect of it. The most important thing is that we grew again to 51,000 lives. We brought in a very large provider, what's now Intermountain Health, and we were really happy, and we were growing in the north. So at one point, it was only like 3,000 lives out of the 40,000 lives were up in the north. Now it's almost 19,000 lives. So it's been really, really beneficial from our perspective to be able to get Northern Nevada involved in this because, again, they're about 35% of our population, But it's a good thing for where we're going. 55 practices in 21, approximately 45,000 lives. And you'll see this thing about attributed lives. It's the stupidest word you could have in the English language, 2 words. Because if you go to a cardiologist 4 times during that year and you go to your primary care 3 times, we don't get attribution for that patient. We don't get credit for that patient unless that cardiology group, in our case we do have 3 cardiology groups, are in the ACO. So one of the ways we've been able to prevent that from going backwards to specialists is by this chronic care management monthly. It's a once-a-month charge. It counts as a visit. Therefore, we can start moving patients back into the primary care's responsibility. But this attribution should really be only based on people who are going to a PCP, not their specialist. But again, that's the government. We have to live with it. That's where we're at. So what have we basically on our historical trends? And again, this is the stuff that we say we can be really proud of. Our first year original benchmark, and again, this was the prior cost that Medicare believed that was costing us to run our patients, $10,360, and the actual spend was $10,615. That's why we lost money. Benchmark, actually updated benchmark, and then actual spend. We spent more than they predicted they would have spent without us. So we were a little disappointed. But the next year, we got some of our information together. Our benchmark was $11,281, but our actual spend was $10,008, so going back to under $11,000. So if you look at that, we then saved Medicare $6.268 million, or we earned out of that 50%, that's why it's never 50%, we actually got $2,600,000 back. So we made money. We didn't recover the loss, but we made money, and our shared savings percentage was 3.81. So we were very, very happy, to say the least. And then if you look at 16, we went up to $15 million in savings, $14 million in 17, and then the roof just kind of all came off and everything happened. The skies opened up, the sun shined right on us with, PF 95, I'm sure. And we had $33 million in savings. So we went, boom, right up to the top of the list in the United States of what we were doing. It took us 4 years, but we were never trying to push data down to a doctor to say, do it. We weren't MMA fighting these guys. We were coddling them. We were asking them, what can we do? What can we help you do? How can we help you help your patients? And it just, everything just was amazing. 33 million. In 19, we even went past that. We went to $48 million in savings. So we knew we had something that was right. We were doing it the right way. I have a couple conservative people on the shareholder side of it. I wanted to go to risk. I said, why are we giving the government 25% of that when we can go 75-25? Well, if we screwed up, you know, I got to take it out of my wife's savings because she didn't give me any of it. So, but we chose to stay with a 50-50. But then we went in 2020, we went to the 75-25. We said, let's take the risk. If we have to give the money back to the government, what's our worst case scenario? 17, 18, $20 million. But our upside is another 10 or $12 million that we would have given them that we don't have to give them because we believe what we were doing is right and we believe the process was going to stay correct. And so we ended up with, instead of getting 21 million, we got $32 million in savings. So again, in those 6 years, $162 million total savings to the government and the way they define savings, of which we got $86 million back into our situation. In 19, we had a 10.26, which at one point, they weren't going to give you credit if you went over 10% in savings, and they finally kind of got rid of that and said, well, why should we penalize you if you just keep getting better? But our benchmark is the problem, is that the more you save, it's harder to save that much more the next year. So they don't keep giving you back, you know, credit for where we started, and there's games to be played with the numbers, but in essence, anything above 5% is absolutely your A student. Anything above 7% is your A plus student. So I'm looking at 10.26, 7.21, and in 2020, 8.44. Overall, in these 7 years, 7.58% savings. So that's why we've been asked to do presentations around the U.S. and talk to people about what have we done. And I can tell you, and Bruce sometimes agrees with this part of it, what we did different than everybody else is we just made it personal. We went in the doctor's office and said, can we become part of your office? Can we give you data that you can do something with, but you don't have to? But if we can help you help that patient, that's all we want to do. We mandate that our quality coordinators are in the office once a month. Now, during COVID, there was a lot of offices that wouldn't let us in, so we mandated the Zoom, which I hate. But we still wanted to have that contact with the patient. One of the best compliments I had, I was out with the doctor in Boulder City, and he was like, you know, I don't remember seeing your staff. I don't even know who it was. And his office manager said, that's their person. It's not our person. That, to me, was the greatest compliment we've ever had. Because he didn't realize it was our staff in there talking to his people and him. He thought it was his person. Okay? Now, I wanted to know, why wasn't I on your payroll if you don't even know who your staff is? But that's beside the point. So the good thing is that if we could do this seamlessly and make it that effortless for them to help themselves, that's all the positive part about healthcare. And actually, that's part of what's wrong with healthcare, is that we don't make it personal enough. I mean, the doctor's sitting here doing this, and you're over there on the table, right? Why can't we move the table right next to the patient so that you look at the patient? And then the doctors have to learn how to type. Because if you still see them, most of them still do this. Our macro, everything, they copy and paste. I was lucky. In high school, I guess that's 12th grade, right? I learned how to type. You know, I don't know what it was, 90, 100 words a minute. But it's benefited me to this day. And the only reason I took typing is because my future wife was in that class. And I figured, okay, well, she's dating my best friend, but I'd like to date that lady. So anyhow, at the end, 43 years later, I got her still. So I'm pretty lucky about that. But I still type faster than she does. All right, so again, shared savings, that's our results. Our opportunity was earned 6 consecutive years. We will know our results, again, it's always late. We will know our 21 results sometime at the end of this month or next month. So I'm taking 2 weeks to go to Europe, so I don't know, because I only want a positive note. And since I'm 9 hours later, I will find out before most of the staff does, like I did last year. But it's terrible to have to wait when they've had this data. and I don't get to see it for 8.5 or 9 months. Improving quality scores, obviously that's huge for us. And when you look at our overall quality score, starting from our first year of 87, going all the way up to, I say 96, but 98.75, our staff really wants to hang on that one. Increasing annual wellness visits and increasing those from 8.6% to 32%, and then obviously going to the chronic care management. So those of you who are fortunate to be 65 or older, and you're not on an HMO, or even if you are on HMO, take advantage of this annual wellness visit. Take advantage of your chronic care management. It is the simplest thing to do. It's very beneficial for you. And if you do get discharged from a hospital, or unfortunately you get admitted to a hospital, have somebody talk to you. There's plenty of discharge planners in the hospitals. They give you all this information, and most of the time you don't know it. The simplest way, and we try to get some of the discharge planners to do it, give them your phone and have them put the hospital's number in, or whatever, whoever's going to call you. Because most of the people, like my mom, if they call it, it just looks like it's a stupid number. It's another phishing number, so they don't answer it. So that's why we have a low penetration of getting that. But if they had put the number in the phone while they're still in the hospital, then they'll see it. Oh, hey, that's Valley Hospital calling me, or that's Summerlin, or whatever hospital it is, or that's ARCOS, that's our care management team calling you. If you can do that, it will help out. So what are our lessons learned? Keep the practice office, or the office staff, informed. So one of the things that we did is we got our doctors in the savings to give us some money so that we could have quarterly meetings, and if the office staff showed up, at the end of the year, we would take the money they gave us and we'd divide it by the number of times you showed up, and it ended up being about $250 per person. So they were getting $1,000, and that was always being distributed right around Christmas. And you'll be surprised, one group came and said, hey, we're only 2 people showing up, and we're bigger than that group, and they show 8 people. I said, they're smarter than you. Bring 10 people if you can. The more people you can bring to the office that we can tell you what's going on a quarterly basis, it's great. Now, it may slice that number down a little bit, but each year the doctors have given me more money to give back to the physician's office staff. That's been a huge success for us. Simple thing. And we did have to ask for permission from Mother CMS, but we only told them what we needed to tell them. Purchase services from an experienced company, and keep your providers informed on a regular basis. There are companies, and Rhonda, our COO, and myself, and Carla, Lynn, Upinder Singh, we've gone to these CMS quarterly meetings when they were in person. We were shocked at how many health systems only do the auditing after the year's over. So they can't make any change. You have to be making the change constantly throughout the year. That's why we have our quality coordinators. Every single month they're working on something. You cannot do it after the fact. It's too late. Now all you are is basically an Excel spreadsheet. You can't make any changes after the fact. You can for the next year, but that's it. So all these things, again, between CCM, TCM, annual wellness visits, a lot of EIOs in this, huh? ACO, you know, all the CMS. But that's our world in the ACO business. We're very proud to be in the state of Nevada. The most important thing is you know, we want to have a successful patient atmosphere. We want patients to be engaged. We know patients have a choice, whether it's an HMO or their private physician. But the most important thing is try and stay healthy. Be an Ernie, you know. What are you, 83 now? 87? All right. I lost 4 years of your life somewhere along the line. My wife worked for him way back in 1983 when we moved here. So, yeah. So she still is mad at me about that. But nonetheless. The physicians sign the contract with the ACO for a calendar year. Well, we do. If their quality scores are not there, we've dropped people because they just don't want to let us in the office. If you're not going to let us in the office, then why be in the ACO? Well, they want their check. I'm sorry, that's not going to happen. So, yes, we have dropped some people here.
I have a question. So from a post-acute care standpoint, do you have, or does the ACO have any plans of gain sharing with community partners like that?
We haven't at this point in time, because there isn't really a way to say how much of that gain share is from the hospitalist, how much of the gain share is from the whether it's an ECF or, you know, the SNFs or the LTACs and stuff like that. We don't get enough data to be able to say, how do we prevent that change, or how do we implement that change?
I'm kind of comparing that to the BPCI
yes.
program.
And yet,
and that plays, you know, there are some that do that.
There's a crossover in that.
Yeah.
Yes, big crossover in the BPIC. Yeah. So, Todd?
There's the results are spectacular.
Thank you.
I'm so impressed with what you're able to accomplish. Listening through your presentation and having known that half the market left the market because they were unable to do what you did.
Right.
I see the secret sauce seems to be in your quality coordinators that are embedded in the practice.
Right.
How big is that? How does that operate?
All right, so great question. So we went through, and as we were going through this stuff, and my background is accounting, and so I wanted to put some numbers to it. So we realized that about 4,500 patients can be handled by one quality coordinator. 4,500 patients. But think about it, that's one doctor has about 35 in internal medicine, about 3,500 patients, about 4,500 for family medicine. So really it wasn't too, it sounds huge, but most of those patients don't also go into the system. So if we have 45,000 patients, then I need 10 quality coordinators. Then I've got a director of the quality coordinator, then we got our COO, and then me being the figurehead,
So it's not as, I was thinking it was going to be larger than that. So
No.
it's about 10. Are they nurses? Are they?
No, they're people who've worked in the physician offices, either an MA or front desk, it really doesn't matter. But they have to have obviously medical terminology, they got to be able to have a rapport with the staff. Rhonda's an LPN, so obviously, she's got the background, the medical training to do all that stuff as her COO. But realistically, it's just giving the data back to the doctor in a concise way.
So I do have a secondary question.
Yeah.
Have you created a real-time dashboard for the physician office?
Yes, and they get that, we call it a gap in care report. They get that monthly. So it'll tell them all their patients, and it'll tell them what scores they've made or what scores they haven't even scored yet. So they get that every single month. They have to sign off that they've received it, because I've had doctors tell me they've never seen it before, and I think that's your signature. Oh. And you got to know, if you're in the medical field, half the doctors sign stuff, they don't have a clue what they're signing, right? Here, at least, maybe I should have, Sergio go ahead and videotape the damn thing for us, or Diego do that for us. Somebody, in our office could say, hey, take a camera and put it on your phone, verify that you're really there. Because again, we're trying to help them. We're trying to save money for the system if possible, but we're trying to improve the quality of care to that patient. And if we can do any one of those three things, the patient should live a little better, if we're lucky, as healthy as Ernie, and keep moving, and don't spend the money. I mean, the worst scenario, and this was true back in the 70s, 80s, 90s, 2000s, 75% of the dollars spent on the seniors in their last 6 months of life, right? That's wrong. Now I'm not in for, assisted suicide and all that stuff. If people want to do it, that's fine, that's their choice. But why not have the right life as you're living, and then when it's time to go, there is a process. Everywhere else in the world, almost, that's a normal thing. They call it queue. You get in a queue. Try and get an ultrasound in London, it could take you 6 weeks. In Canada, it could be 6 months. In Mexico, I have a clinic in Mexico. We've had to bring staff up here to get something done because they're just not going to be able to get it done.
It's still 3.5 months to get this to
In this town, that's bad. Yeah, and again, we're not only short in, and I think Carla did a presentation at one of the meetings a few weeks back, but they say we're 4,500 primary care short in the city. Psychiatry is the most needed thing, and yet nobody wants to do it because the insurances just will not pay. They can get a $450 visit on cash, and the insurance company will pay them $100. Why do that? So they just go cash. They see half the patients and make twice as amount of money. It's really, the system is bass-backward. One of the things that I've promoted since day one in healthcare, and again, going back to the early 70s, is there's no disincentive for a patient. That's what's wrong with our system. So I don't smoke. I'm a light drinker. I mean, my wife and my 3 kids outdrink me. I'm maybe a beer and a half into it, and I'm either a lush or I'm tired. I'm asleep. I mean, I don't handle alcohol very well. But I also don't take care of myself, so I have good genes. I thank my mother for that. But where's the incentive for me not to go to the health care provider? There isn't. I think there should be more of an incentive for the patient to be charged more to have something done, to have some sort of a program that they are forced to go in and see their provider. When my mom was a teacher for 42 years, we had California dental insurance. Whether I liked it or not, every 6 months I had to go to the dentist, otherwise the premiums doubled. So my mom drug all three of us into the dental office, and we sat there, and I don't know what they did, I didn't care, but we had to show up, otherwise her premiums doubled. So that was the greatest incentive to me to be able to get our dental care done. So worked well for my brother and my sister. I just ate too much candy.
Savings that you accrue that go back to the government, that gives them the opportunity to buy more ammunition, to hire more IRS agents?
Bingo, yes, yes. Yeah, Uncle Joe's really happy about that. Yeah. But again, it goes back to everything else. You know, whatever you're going to do, the government always going to take the vast majority and take all the credit, right? But they gave us the opportunity to do something, and that was the most important. We then took that opportunity and made something out of it. And it's not like we couldn't do more, but at the other side of it, if we get too intrusive into the office or too caustic to the doctor, they're going to walk away. So we've got a very fine road that we do, you know, working with a physician in their groups. So. How did we do it? Well, Bruce Wiggins, Alan Sklar, Mickey Duke. Bruce actually came up with the idea. I give him credit for that. He had socks and hair at the time, but you know, but he kind of said, look, this is a demonstration project. Why not get involved in something like this? And as soon as I heard that, I was like, wow, I think we can do something with it, because the doctors, and I've worked with them for 49 years, they don't have this information. So how can we then do something like that? And originally we just assumed it would be the four of us would do this. And then eventually it was like, well, we brought in Kindred, we brought in the Valley Health System. They've been great partners. They were able to fund, you know, some of our issues, but it's a risk. And the physicians, to be part of this, do not have to pay a dime to be in it. So they have no risk, only reward. So that's where it is. Yeah.
Is that longitudinal data, or is that like?
So Medicare sends us every single month, millions of line, every single claim that is paid, we get it now, just like an HMO or the third-party administrator. So we get all that data, and then we go through our own little algorithm, and it tells us how many visits were attributed to that primary care doctor, and then based on that, that gets attributed to that primary care doctor.
So do you guys have like some sort of like a master patient index?
It is massive. And Raina over here takes care of that. She sends that to Experian and to, who's our other company? Our data resource. Clinigens, yeah. It was Health Endeavors for 6 years. Clinigens has been the last 2 years. They have to have the resources to do that. We could bring our own IT people in, but again, going back to one of my comments, why bring in people that will have to learn something who have people who already know all this stuff and are spending hundreds of millions of dollars improving their own resource technology. So I don't want to be in that business. I want to be in the business of looking at the data that somebody's given me. We get to write and customize our own reporting out of it, what we want out of it. And then we have these dashboards that are in color, that are graphs, and you'd be surprised at how much of an argument that is. Well, the doctor doesn't like it that way, and this doctor likes it that way. Whatever way you want it, we'll figure out how to give it to you.
Do you see like an importance for like just like data interoperability between different like hospitals, and where do you guys stand on that?
Well, no, that's why I said Healthy Nevada, they get everybody, and telemed data, they get everything here. If we could figure out how to do that, that would be useful, it'd be great. But right now, we're not there.
Why is that?
It's just you've got hundreds of softwares out there, and even though they're HL7 compliant, they don't work with each other. You know, this guy's got first name, last name, middle initial. The other program has last name, middle initial, first name. So you got to map every one of these codes to every single software, and every time they do an update, it changes. So until you just have a platform that's consistent, then what you're doing is you're getting people who are, and this is where Healthy Nevada and stuff, they're giving you PDF data. All right, it is searchable, but how much time do you have to do that? So we're in a lack of technology.
Stay
All right, well, real quick, Bruce, I'll let you do that, but I want to remind you, if all of you guys are here, we have a great program coming up, the Nevada Healthcare Forum. It's a one-day program, October 6th. Please, if you haven't seen it, go through it. And the other thing about this medical community that's great is we have an entity called the Nation of Patriots. It started in Minnesota. And this community here is given more to that organization, and all that money stays here. We've almost $250,000 in the last 5 years, and our golf tournament. So the vendors that are here that have supported us, we appreciate that. We gave $40,000 this year to it. It's one of the largest in the United States that we do. But again, it's a community helping our own community, and that's what we're all about. All right, Kelly.